Assalamualaikum and good day. Today we are going to look at tumors of the CNS and the peripheral nervous system. In this lesson, we are going to classify the brain tumors, discuss the special characteristics of brain tumors, differentiate tumors arising from astrocytes, whether they are low grade or high grade, whether they are infiltrating or non-infiltrating, discuss the features of meningioma and medulloblastoma, discuss briefly on lymphoma, germ cell tumors, and metastatic tumors in the central nervous system. And we're going to look at the peripheral nervous system tumors, which are neurofibromas and familial tumor syndromes. The annual incidence of tumors of the CNS ranges from 10 to 17 per 100,000 persons. About half to three-quarters are primary tumors and the rest are metastatic. Tumors of the CNS account for 20% of all cancers of childhood. For primary malignant brain tumors, the most common signs and symptoms are seizures and headache. For benign tumors such as meningiomas, the most common symptoms are headaches, mental status changes, and weakness of the muscle or paresis. And the most common signs are paresis and memory impairment. Looking at the Sarawak data from January 2009 to December 2012, the incidence of brain tumor was 4.6 per 100,000 persons per year. Meningioma was the most common brain tumor, followed by astrocytoma. Brain metastasis accounted for 15% of the cases, and lung cancer was the commonest primary. Medulloblastoma and astrocytoma were common in pediatrics. We go to the classification of brain tumor. It is first divided into primary and secondary or metastatic. The primary tumor of the brain is divided according to the cell of origin. If it arises from the glial cells, they are called glioma. If it derives from the meningothelial cell of the arachnoid, it gives rise to meningioma. Poorly differentiated cells gives rise to medulloblastoma. Germ cells gives rise to germ cell tumors. If it arises from the lymphocytes, it can give off lymphoma, and if it's neuronal or ganglion cells, they can give rise to its own tumors. We now look at the special characteristics of the CNS tumors according to age and location. A term called malignant by location, the characteristic of its spread, and the characteristics of grading of the CNS tumors. 70% of childhood CNS tumors arise in the posterior fossa, infratentorial, compared to the number of tumors in adults, which mostly arise above the tentorium. Medulloblastoma and pilocytic astrocytoma, for example, are mostly childhood tumors, and they are mainly seen in the cerebellum, which is infratentorial. In pathology, we classify the tumors, whether they are benign or malignant, on the histologic features. But for CNS tumors, the clinical course of the disease is also influenced by the location and patterns of growth of the tumor. Some glial tumors with benign histologic features may infiltrate large areas of the brain, and that may lead to serious clinical deficits and poor prognosis. Any tumors can have deadly consequence if it is located in a critical region. For example, a benign meningioma may compress the medulla, causing cardiorespiratory arrest. Hence, the term malignant by location. CNS malignancies are locally invasive. Even the most highly malignant gliomas rarely metastasize outside the CNS. The subarachnoid space provides a pathway for spread, so seeding along the brain and spinal cord can occur. Some malignant pediatric tumors spread through the CSF when they encroach on the subarachnoid space, resulting in cerebrospinal dissemination far from the original tumor site. Treatment protocols for the CNS tumors are currently based on the World Health Organization classification, which groups the tumors into one of four grades according to their biologic behavior. Grade 1 tumors are slow-growing, non-malignant, and associated with long-term survival. Grade 2 tumors are relatively slow-growing, but sometimes recur as higher-grade tumors. Grade 3 tumors are malignant and often recur as higher-grade tumors. Grade 4 tumors reproduce rapidly and are very aggressive malignant tumors. Malignant brain tumors tend to progress and become more aggressive with time. For example, grade 3 tumors can develop and progress to grade 4 tumors. Seizures, which are caused by disorganized electrical activity in the brain, is usually the first sign of gliomas. Seizures can cause a loss of consciousness, involuntary movements, or loss of muscle control throughout the body. Other people have symptoms due to swelling around the tumor or blockage of the normal cerebrospinal fluid flow. Symptoms can include headache, nausea, vomiting, diminished consciousness, weakness or numbness, and loss of mental sharpness. The area of the brain affected by the tumor determine the specific symptoms. Gliomas are the tumors that derive from the glial cells, such as astrocytes, oligodendrocytes, or ependymal cells. They are named astrocytoma, oligodendrogliomas, and ependymoma. These tumors range from an extremely benign tumor which may not progress, such as pilocytic astrocytoma, to the most malignant of brain tumors, glioblastoma multiforme. The two major categories of astrocytic tumors are infiltrating astrocytomas and non-infiltrating astrocytomas, of which the most common are the pilocytic astrocytomas. These tumor types have characteristic histologic features, distribution within the brain, age group typically affected, and clinical course. Non-infiltrating astrocytomas usually grow slower than the infiltrating forms. Among the infiltrating astrocytomas, there are diffuse astrocytoma grade 2, anaplastic astrocytoma grade 3, and glioblastoma multiforme grade 4. Infiltrating astrocytomas account for about 80% of adult primary brain tumors. They are usually found in the cerebral hemispheres, but they may also occur in other sites. They are most often found in the 4th through 6th decades of life, and the most common presenting signs and symptoms are seizures, headaches, and focal neurologic deficits. Infiltrating astrocytomas show a spectrum of histologic differentiation that correlates well with clinical course and outcome. You can see there's a tumor at the septum pellucidum here. This is diffuse astrocytoma, and in the right picture you can see there's an expansion of the gyri here, which led to the flattening of the gyri, and this is also diffuse astrocytoma. In diffuse astrocytoma, you can see mild increase in the glial cells with no nuclear pleomorphism. There's no necrosis, no mitosis, and no vascular proliferation. So in the picture, you can see the cells are mildly increased compared to the normal area. Now we compare the diffuse astrocytoma, which is grade 2, with glioblastoma multiforme, which is grade 4 or high grade. So grossly, can see this area of necrosis and hemorrhage, and it usually is well demarcated, and the tumor can cross the corpus callosum. In this picture, you can see that the tumor is cellular, yeah, and there is this pseudo palisading. You can see this is the border between the cellular areas and the necrotic area. Yeah, so you can see the necrosis. This is the necrotic area. So the cellular areas are bordering the necrotic area. So this is pseudo palisading necrosis. Okay, and you can also see other features like vascular proliferation and nuclear pleomorphism and many mitosis. This is a feature of vascular proliferation that we can see in glioblastoma multiforme. Yeah, so these are blood vessel proliferation. They look like glomerulus. So this is vascular proliferation, and you can see here are the nuclear pleomorphism and hypercellularity that we can also see in glioblastoma multiforme. Okay, so glioblastoma tends to occur in one of two clinical settings, most commonly as new onset disease, typically in older patients, and this is called primary glioblastoma. If it occurs in younger patients with a past history of lower grade astrocytoma, this is a secondary glioblastoma. The type of mutations that they have also differ. The secondary glioblastoma have mutations in IDH1, IDH2, and P53 mutations, whereas the primary glioblastoma have IDH wild type mutations and MDM2 mutations. The prognosis is significantly better in secondary glioblastoma. Histologically, the tumor is indistinguishable, but they are different in their genetic profile. The symptoms of astrocytomas depend on their location and growth rate. So grade 2 may present as a stable or progressively slow growth, and the mean survival is more than 5 years. Radiological findings will show a non-enhancing mass with adjacent edema. Okay, this is because these high-grade astrocytomas have leaky vessels. Yeah, so this is usually seen in glioblastoma, the ring-like features on MRI. So low-grade astrocytoma progress slowly. They have good survival rate with a mean survival of more than 5 years. Whereas glioblastoma, they have rapid worsening of symptoms because of the rapid tumor growth. They have poor survival rate. The prognosis is about 2 to 4 years for secondary glioblastoma, whereas it is worse in primary glioblastoma, which has a prognosis of 6 months to 2 years. We have covered the infiltrating astrocytoma. Now we go to the non-infiltrating astrocytoma, which is a pilocytic astrocytoma. It is distinguished by their appearance and relatively benign behavior. It affects children and young adults. You can see that it is cystic with a mural nodule here. It affects the cerebellum mainly, but it can also involve the other sites such as the ventricles, the optic nerve, and the cerebral hemispheres. These tumors grow very slowly and may be treated by resection alone. So they can have recurrence, and incompletely resected lesions are treated with repeat surgery, chemotherapy, or targeted therapies. This is what they look like on microscopy. It is a cellular tumor with increased blood vessels. they have these rosental fibers, which are thin hair-like processes. The next type of gliomas is oligodendroglioma. They can be grade 2 or grade 3. They are originating from the oligodendrocytes. They usually affect the cerebrum with a predilection for the white matter, and they have the best prognosis among the glial tumors. They affect the 4th to 5th decades of life, and the current treatment with surgery, chemotherapy, and radiation therapy gives an average survival of 15 to 20 years for grade 2 tumors. So this is what we'll see under the microscope, these tumor cells with cleared cytoplasm, and they have these halo-like features. Okay, so this is oligodendroglioma. Another glioma is ependymoma, which can be grade 2 or grade 3. They originate from ependymal cells. They are usually associated with the ventricular system, so they can manifest with obstruction to the ventricles, causing hydrocephalus. In adults, the spinal cord is the most common location, and the tumor can be associated with neurofibromatosis type 2. So here you can see the tumor growing into the 4th ventricle, and it compresses the surrounding tissue. Okay, so this is ependymoma. Meningiomas are predominantly benign tumors of the adults. They usually attach to the dura, and they arise from the meningothelial cell of the arachnoid. You can see here, this is a layer of the dura, and these are the tumors. They are quite round and they are quite rubbery, and here you can see they are compressing the underlying brain. But you can actually separate the tumor from the brain. Okay, so they are mostly benign grade 1, although we can have atypical grade 2 or malignant meningiomas grade 3. Microscopically, the classical features are the neoplastic cells arranged in sheets or walls with presence of psammoma bodies like these ones. And on closer magnification of the psammoma bodies, you can see these calcified bodies. You can also see this whorling pattern of neoplastic cells, just like the whorling pattern of your fingerprint. Yeah? So some do have intranuclear inclusions, just like in these ones. So most meningiomas have relatively low risk of recurrence or aggressive growth, and they are considered a benign tumor, WHO grade 1. Meningiomas are slow-growing tumors, with patients usually having no symptoms at all. The ones that do have symptoms develop seizures, changes in visions or hearing, or arms and leg weakness, especially when there is brain compression. Meningiomas are usually solitary, but if they can also happen in multiple sites, especially when it is associated with neurofibromatosis type 2. They express progesterone and estrogen receptor, so they can grow rapidly during pregnancy. There is a female predominance, and the prognosis depends on the grade. Grade 1 has excellent prognosis. Grade 2 have a high recurrence and they are more aggressive, whereas grade 3 has high recurrence and have high mortality rate. Prior radiation therapy to the head and neck is a risk factor for meningiomas. Now we look at medulloblastoma, a pediatric tumor that is described as embryonal because they appear primitive or undifferentiated. Medulloblastoma is predominantly found in children and is found exclusively in the cerebellum, just like in the picture. They are part of the small round blue cell tumor. They can disseminate through the CSF and may obstruct the CSF flow, causing hydrocephalus. They can also metastasis to the chorda equina. Grossly, you can see there is a tumor here. It's quite well defined. They are grayish in color and they're quite friable. They are fragile on touch. And macroscopically, you see extremely cellular tumor composed of small tumor cells with scanty cytoplasm and hyperchromatic nuclei. Sometimes we see rosettes with central neuropil. Medulloblastoma is a highly malignant tumor. The prognosis is very poor if they are untreated. And it also depends on the amount of tumor that is resected. The more tumor that is excised, the better the prognosis. The tumor is also very radiosensitive. So with total excision and irradiation, the 5-year survival rate is about 75%. The symptoms that are associated with medulloblastoma are secondary to increased intracranial pressure. So you get mostly the classic triad of morning headaches, vomiting, and lethargy. Other types of tumors that can affect the central nervous system are neuronal and ganglion tumors that can be derived from ganglion cell tumors such as gangliocytomas, mixed ganglion and glial cell tumors such as gangliogliomas, tumors with neuronal elements such as cerebral neuroblastoma, and tumors with glial and neuronal components such as dysembryoplastic neuroepithelial tumors. Primary CNS lymphomas accounts for 2% of extranodal lymphomas and 1% of intracranial tumors. Lymphomas are the most common CNS neoplasm in immunosuppressed individuals, such as patients with AIDS and patients with immunosuppression after transplantation. Most CNS lymphomas are diffuse large B-cell lymphomas. They are aggressive and respond poorly to chemotherapy compared with peripheral lymphomas. Primary brain germ cell tumors occur along the midline, most commonly in the pineal and the suprasellar regions. They affect mainly the young people, 90% occurring during the first 2 decades of life. The germ cell tumors share many features with their counterparts in the gonads, such as the testicles and the ovaries, and there are 5 major types: teratomas, dysgeminomas, choriocarcinoma, embryonal carcinoma, and yolk sac tumor. Metastatic tumors to the central nervous system accounts for 25 to 50% of intracranial tumors. The most common primary sites are the lung, breast, skin, kidney, and the GIT. Metastatic tumors present clinically as mass lesions and may be the first manifestation of the cancer. Mets to the epidural or subdural space can cause spinal cord compression. Primary lung tumors account for about 50% of all metastatic brain tumors, and lung cancer is the most common origin of metastatic disease. Breast tumor is the main source of metastatic disease in women. On MRI, if we look at this picture, you can see at least 4 metastatic lesions, and you can see there's an area of edema, which is this darker region around the dense area. This is edema, this is the metastasis. Okay, so on gross, we see these multiple lesions with hemorrhage. You can see this quite liquefactive necrosis is happening here. Okay, and most often we see this metastasis at the junction of the gray and white matter. Okay, now we look at peripheral nerve sheath tumors. These are the tumors that arise from cells of the peripheral nerve including Schwann cells, perineural cells, and fibroblasts. There are three important types, which are schwannomas, neurofibromas, and malignant peripheral nerve sheath tumors. The various forms of peripheral nerve sheath tumors are also associated with the two forms of neurofibromatosis, which we will look later. First, we look at neurofibromas. Neurofibromas can present as discrete localized masses, most commonly as cutaneous neurofibroma, or in the peripheral nerve as a solitary neurofibroma, or as an infiltrative lesion growing within and expanding a peripheral nerve, that is plexiform neurofibroma. So the occurrence of cutaneous solitary neurofibroma can be seen in sporadic cases or in patients with neurofibromatosis type 1. Diffuse neurofibroma is associated with NF1, and plexiform neurofibroma is exclusively seen in NF1 patients. The risk of malignant transformation is quite significant in plexiform neurofibroma, with 5 to 10% risk of malignancy. The site of plexiform neurofibroma, it is seen in the large nerve trunk, whereas cutaneous neurofibroma are seen in the dermis, and solitary neurofibroma are seen in peripheral nerve. Diffuse neurofibroma are seen as a large plaque-like elevation of the skin. Cutaneous neurofibroma are usually circumscribed skin lesions covered with skin, and microscopically it is composed of collagen and spindled Schwann cells in this area around the epidermis, whereas diffuse neurofibroma are diffuse but localized involvement of the skin and subcutaneous tissue, just like in this picture here. Plexiform neurofibroma may arise anywhere along a nerve, although the large nerve trunks are most commonly involved. They are frequently multiple, and the presence of either multiple neurofibromas and plexiform neurofibromas strongly suggests the diagnosis of neurofibromatosis type 1. So this patient has a large neurofibroma, plexiform neurofibroma affecting the nerve trunk at his buttock. Malignant peripheral nerve sheath tumors are highly malignant tumors that are locally invasive and frequently with multiple recurrences and eventual metastatic spread. Close to 50% of cases arise in the setting of neurofibromatosis type 1, either from transformation of a plexiform neurofibroma or following radiation therapy. We have had cases where patients with multiple cutaneous neurofibromas who are working in the fields as farmers, eventually one of the neurofibroma, the cutaneous neurofibroma, grows bigger than the rest of the neurofibromas, and then when we take biopsy, there is malignant transformation of the neurofibroma, and that malignant transformation transforms into malignant peripheral nerve sheath tumors. So this one produces the fusiform expansion of the sciatic nerve, and there's foci of necrosis and hemorrhage that characterize the aggressiveness of the tumor. A variety of inherited diseases are associated with the occurrence of tumors. In most, the pattern of inheritance is autosomal dominant, with involvement of tumor suppressor genes. Is characterized by development of neoplasm and hamartoma throughout the body. So hamartoma is a benign tumor-like nodule composed of an disorganized overgrowth of mature cells and tissues normally present in the affected part. The ones that affects the central nervous system are neurofibromatosis type 1, which we will see in detail, and neurofibromatosis type 2, tuberous sclerosis, and von Hippel-Lindau disease. Neurofibromatosis type 1 is a familial tumor syndrome that is characterized by the presence of neurofibromas of the peripheral nerves, gliomas of the optic nerve, pigmented nodules of the iris, and cutaneous hyperpigmented macules, such as cafe au lait spots, as in the picture. So it is because of the defect in the NF1 gene, which is a tumor suppressor gene. You can see that this patient is having numerous cutaneous neurofibromas all over the skin, at the back and the front. And in another patient, she's having a plexiform neurofibroma, which is the nerve sheath tumor that surrounds multiple nerve fascicles. So there is a tendency for plexiform neurofibroma in patients with neurofibromatosis type 1 to undergo malignant degeneration. This patient may also develop gliomas of the optic nerve, other glial tumors, pheochromocytoma, and hamartoma. Another similar familial tumor syndrome is neurofibromatosis type 2, which is also an autosomal dominant syndrome. It is associated with bilateral 8-nerve schwannomas and multiple meningiomas, and is less common than neurofibromatosis type 1. So these are the references from the Robbins 2021 edition. Thank you very much.